Next, we have Gonçalo Mesquita, and the session name is Vision in Stroke Rehabilitation. Please welcome.
Hi. Hi. Good afternoon. And we'll just share the slides. 1 minute. Can you see it?
Yes, it is visible.
Okay. So hello everyone, my name is Gonçalo. I was a researcher at the Institute for Systems and Robotics. I did this work with PhD student Ana Rita Coias and Professor Alexandre Bernardino. I also had the pleasure to work with Professor Otto Dubrovsky, which was a professor from Carnegie Mellon University, where I participated in the program SMU Portugal, where I spent 3 months at SMU, where we developed this work. So our research topic was mainly stroke rehabilitation, more specifically creating pseudo-label frames to do real-time evaluation. Sorry. So 15 million of strokes occur every year. From those who survive, 80% lose their motor function and have the need to do rehabilitation exercises. From feedback of the physiotherapists, the patients normally tend to improve. However, there are two main challenges. The first one is the shortage of physiotherapists, and the second one is the mobility of the patients who lost their motor function. So nevertheless, with the help of computer vision and deep learning, it's possible to introduce a virtual coach that can help physiotherapists to analyze the patient movements. The big objective of this virtual coach is to detect compensatory movements and give feedback in real time. For example, if the patient is doing an exercise like brushing his hair, the virtual coach should detect a compensatory movement like a shoulder elevation and give the correct feedback. In this direction, there was work already being done. The first work is done by Min Hun Lee and Professor Alexandre Bernardino, where they are able to evaluate the quality of stroke rehabilitation in terms of smoothness, range of motion, and compensation. The second work is done by Ana Rita Coias and Professor Alexandre Bernardino, where they are able to learn which type of compensatory movements the patient is doing and give real-time feedback. Although these techniques are already very good, they have two main challenges. So it's very difficult to generalize across patients. If we have a model trained in one characteristics patients, it's very difficult to generalize. And also for giving real-time response, we need to have frame level labels, and they are very time consuming. Therefore, we developed this pipeline. So our input is a video trial of the patient, where it goes through an algorithm that gets the skeleton of the patient that is called media pipe. This goes to our model A, which is a model used for video classification. Afterwards, we use silency maps, so basically gradient methods to obtain information about the model A classification. And then we use pseudo-label selection to detect which labels, frames are more important, and therefore we create our frame level pseudo-labels datasets. Afterwards, we compare these pseudo-label frame datasets with the ground truth that we also have. We have ground truth for each frame in model B. So we basically use an MLP to compare the pseudo-labels with the ground truth. To be able to generalize better, we try different models. So we first use action transformers and skateformer that are specific for action detection. And we also use a foundation model called Moment that it's more specific for time series. Our data set is called SERE, which is a rehabilitation data set. We use 18 participants. They perform 5 exercises: brush hair, brushing teeth, washing face, putting on sock, and hip flexion. Each does 10 movements per exercise, which gives us 1,200 videos. We have the label of general compensation. We have labels to the video level label and to the frame level label. So the video level label, they are used for model A, and the frame level label is used to compare in model B. So let's see the first results of model A, where we perform the video classification for general compensation movements. So for a baseline, we use the LSTM, but basically we can see that the moment is the best model to generalize across patients. We basically use the lasso technique, which means that our test set is a different patient that were used in the training set, and we can check that the LSTM is the worst to generalize across patients, having almost a mean of 0.5, which means it's almost random. Now we can see that moment is the best one to generalize across patients, having a very good trade-off on the majority of the patients of true positives and false positives, being able to keep high true positive rates, while the false positive rate is low. For the silency maps, where we extract the features from model A, we use 2 methods. We use integrated gradient and vanilla gradient. So this is the integrated gradient methods. This is an example where we can see that the patient does the exercise of brush their hair. So they use their left hand to do an exercise as brush their hair, and they use the joints 11, 13, 21, 19, 17, and 15. And we can see that, for example, in the model LSTM, the most where the model pays the most attention are exactly on those joints. So we can see the moment that the model detects when there is a compensatory movement. For the action transformer and moment, they are a bit more pinpointed, while the LSTM has a more spread attention, and the skateformer is even more pinpointed. We then used a method called pseudo label selection method, where we basically decide a threshold to the scores. So we sum up each of these attention maps in through each joint, where we obtain this score, and then we use pseudo label selection method to decide when there is actually compensation. So everything that is above the threshold, we consider a compensation movement for that frame. And then we are able to obtain these pseudo label datasets for each model. We compare directly these pseudo label datasets with the ground truth, and these are the results. We can see that for vanilla gradient methods and for the integrated gradient methods, the LSTM is the better model. However, we then use a double threshold method. So the objective is to take out the frames that we are uncertain. So basically, in the middle, we don't use those frames. So everything that is above the first threshold is a compensatory movement, and everything that is under the second threshold is a normal movement. We then compare these pseudo-label datasets again with the ground truth, and we can see that for the vanilla gradient, the action transformer is better, and for the integrated gradient, the LSTM is better. However, then we finalize by using model B, and we compare these pseudo-label datasets with the ground truth on the performance of an MLP, and we obtained that. We can see that the action transformer with the method integrated gradient and the skate former with the method integrated gradient are better than using the ground truth to train. So basically here we use the pseudo labels to train and test in the ground truth, and the reference is training with the ground truth. So we can see that actually the pseudo label data sets that we created for each frame using the action transformer and skate former are actually better than the ground truth. We can also conclude that moment in our first results in terms of video classification is the better model to generalize across patients. And therefore, we reduce the effort for frame level annotations in stroke rehabilitation. Thank you very much. Any question? Sorry, I think you are muted. Sorry.
Oh, sorry.
Okay.
Yeah. Can you hear me
Perfect.
now? Yeah. So the video input has been taken in order to know how much the muscles have been engaged with respect to their exercises and all those things. But there are studies in which they are actually taking the tensions and the pressures of each point on the, for example, if hand is supposed to be lifted so much, this much and all. So how could that, I mean, your method is more reliable when compared to that, because there we have sensors which are attached to your hand exactly, and that actually calculates the tension which is exercised by the sensor when they move up and down.
Sorry, can you just repeat the last part?
Okay. See, my question over here is that here the video input has been taken in order to measure how the muscle movement has been made, or how does this helps them with respect to rehabilitation after a stroke. But actually, nowadays they are having some kind of a sensors which are all attached to the wearable sensors like that. Okay, and the patients are supposed to do the exercises along with that, and they are actually measuring the tension which is exercised by the sensors over towards it, and they are measuring how well they are doing that exercise. So how could you relate your work with that? I mean, how reliable is with respect to video and that?
Okay. So basically, for what I understood, we use a camera to capture these people doing the actual exercise. So they might do or might not do a compensatory movement. Obviously, these movements are only detected to a certain degree, so they cannot be very fine grained, because we also are also using media pipe to get the skeletons. So they have to have we can actually need to see like the compensatory movement happening, and maybe where you said you used how do you said you connected something to the hands and were able to detect, right?
Some kind of a wearable sensor. For example, some movement need to be more on lifting your arms this much, and then you have to do for 30 repetitions. But we cannot expect the same in the patient that they are doing it perfectly or not. So they are supposed to wear that glove, and then they have to lift it and they have to push it down the bars. Okay,
Okay.
so through the tension which is being measured on the sensor, they are telling that whether they are doing it perfectly for all the 30 repetitions or not.
Okay. No, I think they just do 10 movements and it's the same exercise. So the total video is basically 2 minutes of the same person doing the same repeated movements for 10 times, basically. Yeah,
Thank you.
you're welcome.
Any other question? Okay, thank you very much, Gonçalo. And
You're welcome.
yes, thank you. So we have the